This interview with Dr. Mary Fristad was originally conducted for a documentary, The True Child Within, about pediatric bipolar disorder. Learn more about the documentary and pediatric bipolar disorder at www.truechildwithin.org.
Beyond the Book. An interview with Mary A. Fristad, Ph.D. Tell us about the book, Raising a Moody Child.
What we were really interested in writing the book was preparing something very practical. It basically talks through in a book form what we do in our teaching groups for parents. Because if you've got a child with a mood disorder, it can be really hard to know what to do. There's a lot of stigma, shame, guilt associated with having a child with a psychiatric condition. If you blast out your knee, you can go ask anybody what sports medicine doc to see, what orthopedist to go see. And not only is there not shame, but there's almost like a little bit of pride involved with that, like, oh yeah, my kid, the athlete, has an injury. But when it's my kid who tried to commit suicide needs to see a psychiatrist or a mental health professional, there's a lot of shame and stigma around that. So people don't know how to ask the questions, they don't know where to turn, they're embarrassed. So the more we can just get that information out in print, in groups, in support groups, education groups, the better. So the more parents can get access to that, I think is a very helpful thing. And what we really wanted to lay out for parents are here are the very practical considerations you need to keep in mind as you are trying to figure out what your child's diagnosis is and what an appropriate treatment plan is and how do you monitor care over time.
Why did you treat bipolar and depression together in one book?
We know that somewhere between a quarter to a half of children who have a depressive spectrum disorder will ultimately convert to a bipolar spectrum disorder. So you may start with depression, but you may not end with depression. So for the people who are currently dealing with depression, when we think about early detection and early intervention, we want those folks to be aware of if all of a sudden they're seeing manic or hypomanic symptoms in their child, how to make sense of that. Because it's not, you can be a great parent, you can have lots of good parental intuition, and you can know that there's something wrong, but if you've had a depressed child who now is becoming manic, just being a really, really great parent with great intuition doesn't tell you what to do next. And suddenly what you need to do next is really different than what you've been doing if you've been dealing with depression. So in one way, it's helping those families dealing with depression to move into how to care for the bipolar aspect. The other piece is that we know within bipolar disorder, the hardest component of bipolar disorder to treat is the depressed phase. We have more extensive data from adults than from children, but we know that if you just map out over somebody's lifetime how much time they spend in episode in mania and how much time they spend in episode of depression, the depression clearly takes up more of their time. And when you look at overall functional impairment, that's where the toll really is taken. The likelihood of suicide really most commonly comes in either during a mixed or a depressed episode. And some of the interventions that we use for depression, for the depressed phase of bipolar disorder, are similar to what you do in treating depression. Now, pharmacologically, there are a number of issues to be concerned about because you can easily, with any physiologic intervention for depression, if you have bipolarity latent within you, you can ignite it. But the other interventions, and there are other components to care that are really important to keep in mind, the psychological, the environmental kind of management that you do for depression doesn't trigger mania when you're doing the psychosocial intervention. So when you're in that depressed phase of bipolar disorder, those kinds of pieces of the treatment can really be used. So in that sense, there's really a lot of commonality, even though the disorders are clearly distinct.
Does this indicate that depression and bipolar disorder are part of the same spectrum?
Well, if we think about if 25 to 50%, and our best data suggest if you follow kids up 2 to 5 years, 25 to 50% will convert to bipolar. That means 50 to 75% don't. Now, if we have a longer follow-up, perhaps those numbers will go up. We don't have the data yet. But it means that half to a majority probably won't flip over. So we could debate until the cows come home what that really means. But in the meantime, we've got kids with depression who need intervention, and those parents and kids need to be aware of the risk factors of what does it mean if all of a sudden you see this very strange and unusual behavior that a clinician would call mania or hypomania? Because management of that is suddenly, on a pharmacologic level, suddenly becomes very different than the management of depression. And so that's just a really kind of early detection, early intervention kind of strategy that we've been using. And the families in group, when we've mixed in our teaching groups, when we run our multifamily psychoeducation groups, it actually works quite nicely to bring these kids together, because if I had to pick the two symptoms that really get in the way for kids with a mood disorder, or the two manifestations, I should say, it's a very irritable mood, and irritability is common to depression and bipolar disorder. Not every child will have an irritable mood, but it's really common in both depression and bipolar. And then the disruptive, aggressive behavior that accompanies that irritable mood. And so in depression, you can get the psychomotor agitation, and clearly in bipolar disorder, you can get that over-the-top excess energy that oftentimes leads to some pretty destructive actions. And so it's that constellation, what parents will typically refer to as my child is raging or having a rage. We've operationalized that in our own studies to look at the irritable mood and the disruptive aggressive behavior. And then we've tailored treatments that help kids and parents. Kids learn how to regulate their mood. Not that we're putting them completely in control and saying it's all up to you, buddy, because that's just not fair. But we give them coping skills so that they can learn to start to self-soothe, so that they can start to make a plan, and that they and their parents can communicate more effectively over what to do when they see, either one of them sees the spiral going upward.
Isn't juvenile bipolar the newest disorder of the month, and isn't it being overdiagnosed?
If you think of a pendulum, any good pendulum swings. And until around the 1990s, almost nobody made a diagnosis. So here's the pendulum stuck up on this side, in the no diagnosis end. Well, any good pendulum, when it swings, doesn't stop in the middle. It swings all the way to the other side before it comes down into the middle. So what we see happening in that swing to the other side is, in some areas, by some practitioners, absolutely not all, the minute you hear irritability and rage, oh, well, that's bipolar. If we have irritability, and what parents often come in saying, my child rages. Some people hear irritability and rage, and with that, on that basis alone, will make a diagnosis of bipolar disorder. But that's not enough. Irritability is to children's mental health what fever is to pediatric care. So hearing that a child is irritable lets me know there is something distinctly wrong in this child's development. It does not give me a diagnosis. This child could have any diagnosis. Until I learn more about what are the symptoms that accompany the irritability, all that I know is that something is wrong. And then I've got to figure out what that something is. So there are, in some instances, in some pockets of the world, with certain providers, you get that pendulum swinging. There's still plenty of people who simply don't believe the diagnosis, or they've heard one or two cases of this pendulum swing. Oh, you know, if everybody's bipolar, then nobody's bipolar. Well, how about if we settle in the middle and say the people who have symptom profiles consistent with bipolar 1 have bipolar 1. If you have symptoms consistent with BP2, you have BP2. Cyclothymia, and BPNOS, that's BPNOS. And if we stick with our criteria they're not perfect, but they're pretty well articulated. If we stick with those, do our research on those, do our clinical trials on those, and provide clinical care based on that nomenclature, I think we're in reasonable hands. Well, you know, one of the interesting things in bipolar disorder is that we can trace back in history and have multiple examples throughout the centuries of people with bipolar disorder. And we know from cross-cultural studies that bipolar disorder exists in all cultures. So when people really question, is this really a diagnosis, to me that provides some confirmation that yes, this is really a real thing. It really warrants treatment, and people can get better with intervention.
There's been controversy whether it's a different disorder entirely in children because the symptoms can be so different from those found in adults.
Well, there's a lot of controversy over the diagnosis, and I think once you get to some symptoms that really can't be explained as long as you've done a drug screen and there's no cocaine or anything else on board, there's no other real explanation for grandiosity, for the kind of the too muchness that occurs in bipolar disorder, the decreased need for sleep, that whole charged up piece. We don't have other disorders that best account for.